The influence of a country's health system on health sector innovation was one criterion considered by judges in a recent bracket tournament on the best healthcare system in the world Austin Fracht and I wrote for the New York Times. For example, though the US lost to France by a score of 3-2 in a semifinal match, it picked up its 2 votes from Ashish Jha, a physician researcher at Harvard University, and Craig Garthwaite, a health economist from Northwestern University, in part because of its influence on innovation, despite the high cost we pay for it. Threats to innovation is a frequently raised concern about moving the US health system too far towards that of any other country. Though there's some validity to this concern, it is frequently misapplied and misunderstood. How exactly does the US health system foster innovation? That's the topic of this week's Healthcare Trio. Special thanks to Austin, because this episode's also adapted from a column we wrote together. First, let's acknowledge that the United States is home to a disproportionate share of global innovation, both within the healthcare sector and more broadly. More clinical trials are conducted in the United States than any other country. The United States is home to the most Nobel Laureates in Physiology and Medicine. More patents are awarded in the United States than anywhere else. And by one account, the United States ranks #1 in overall scientific innovation. The US innovation advantage stems in large part from a first-class research university system, along with robust intellectual property laws and significant public and private investment in research and development. But none of this is quite what Drs. Jha and Garthwaite mean when they say that the United States is the global driver of healthcare innovation. Many technological and procedural breakthroughs in medicine have occurred in other countries. Instead, what's relevant is that the United States offers a large market in which companies are able to greatly profit from healthcare innovation, in part because we spend a lot on healthcare. The US healthcare market, through which over 1/6 of our economy flows, offers investors substantial opportunities. Rational investors will invest in the sector if it is more profitable than the next best opportunity. Dr. Garthwaite said, and I'm quoting, "The relationship between profits and innovation is clearest in the biopharmaceutical and medical device sectors. In these sectors, firms are able to patent innovations, and we have a good sense of how additional research funds lead to new products." High brand name drug prices in the United States, along with generous drug coverage for much of the population, fuel an expectation that large biopharmaceutical R&D investments will pay off. Were US drug prices to fall, or coverage of prescription drugs to retrench, the drug market would shrink, and some of these investments would not be made. That's a potential innovation loss. This is not mere theory. Economists have shown that as the potential market for a type of drug grows, so do the number of new drugs entering that market. MIT economist Amy Finkelstein showed that the enactment of the late 1980s and early 1990s of policies that made the market for vaccines more favorable encouraged 2.5 times more new vaccine clinical trials per year for each affected disease. Other economists have shown that Medicare's introduction of a drug benefit in 2006 was associated with increases in preclinical testing and clinical trials for drug classes most likely affected by the policy. Healthcare innovation can have direct benefits for health, well-being, and longevity. A study published in the New England Journal of Medicine and led by Harvard economist David Cutler showed that life expectancy grew almost 7 years in the second half of the 20th century at a cost of only $20,000 per year of life gained. The vast majority of gains were because of innovations in the care for high-risk premature infants and for cardiovascular disease. These technologies are expensive, but other innovation can be cost-reducing. For instance, in the mid-1970s, new dialysis equipment halved treatment time, saving labor costs. However, questions about the nature of the innovation that occurs remain unanswered. Work by Dr. Garthwaite, along with fellow economists, showed that though Medicare's drug benefits spurred drug innovation, there's little evidence that it led to new breakthrough treatments. One reason is that the enhancement to pharmaceutical profits from the drug benefit was too small. And though high prices do incentivize innovation, other work by Dr. Garthwaite and colleagues suggests that features of the United States insurance market can create drug prices that still exceed the value of the innovation we receive. That we spend so much money on healthcare is not inherent to our idiosyncratic mix of private health insurance and public programs. In principle, we could spend just as much or more under any other configuration of healthcare coverage, including a single-payer program. In fact, we spend a great deal right now through the Medicare program, often held out as a model for universal single payer. Despite the fact that traditional Medicare is an entirely public insurance program, few people make the argument that there's no innovation for treatments in the elderly in the United States. There's an enormous market for types of care largely devoted to older Americans. That's because we're willing to spend a lot for it, not because of what kind of entity is doing the spending, like government or private insurers. In fact, some question whether the innovation incentive offered by the United States healthcare market is too strong. Spending less and foregoing the marginal innovation is a rational choice. Spending differently to incentivize different forms of innovation than we get today is another approach. Dr. Jha said, and I'm quoting here too, "We have a healthcare system with all sorts of perverse incentives, many of which do little good for patients. If we could orient the system towards measuring and incentivizing meaningfully better health outcomes, we'd have more innovations that are worth paying for." Naturally, the innovation incentivized by the United States healthcare system doesn't stay in the United States. It's enjoyed worldwide, even though other countries pay a lot less for it. So there's also a reasonable debate to be had as to whether it's fair for the United States to be the world's subsidizer of healthcare innovation. This is a different debate as to whether the United States healthcare system could be redesigned along a better approach. We can stifle or incentivize innovation regardless of how we obtain insurance and deliver care. Dr. Jha again, and I'm quoting, "We've confused the issue of how we pay for care, market-based, Medicare for all, or something else, with how we spur innovation. In doing so, we have made it harder to engage in the far more important debate. How do we develop new tests and treatments for our neediest patients in ways that improve lives and don't bankrupt our nation?" We like to make videos about topics that sometimes YouTube doesn't like to sell to advertisers, and we're fine with that because we're gonna do what we think is important. But it helps to get support from viewers like you through things like Patreon.com. Patreon is a subscription service that allows you, the viewers, to support the show and the content we create in ways that don't have to go through all the rigmarole with ad fees and all that stuff. You can go to patreon.com/healthcaretriage if you'd like to support the show. We'd especially like to thank our Surgeon Admiral Sam and our research associates Joe Sevitz, Joshua Crow, and Carlos Gallegos. And if I'm pronouncing that wrong, Carlos, you let us know. While we've got you, we'd appreciate if you'd subscribe to Healthcare Triage, like the video, and it's the holiday season, so consider going to hctmerch.com, picking up some Healthcare Triage merch. I also have a new book out. The Bad Food Bible makes a great holiday gift.